In previous meetings, we have focused our videos in the manual extraction technique, which we have called harvesting tricks. Just as a reminder, FUE has two steps. First, the cut or correct use of the handle in order to break the anchorage structures of the unit to the surrounding tissue, and second, the delivery or correct use of the forceps to take off the unit and end up breaking the remaining adherences without damaging the unit. For both is necessary an entire knowledge of the follicular anatomy. As we have been repeating these years, the follicular adherence is the most important factor when evaluating the difficulty of extraction. This defines what holds the unit to the dermis and subcutaneous cellular tissue. So if the superior segment with its nice sebaceous gland usually measures more than 1 mm and the inferior part varies its diameter according to the number of hairs, how can we get viable units with a 0.75 mm punch? Answers are based on the study we made in 2006, and conclusions are: the best level of cut has to be below the sebaceous gland and cannot overpass the insertion of the erector pili muscle. The partial section of the gland and muscle in the superior segment does not influence in the survival of the follicular unit. And last, the fibrous sheet of the inferior segment forms a virtual space with the surrounding tissue, allowing its atraumatic extraction once the adherents of the superior segments are cut. In the video, we can clearly see how units with more than 2 hairs usually present their branches separated. We can observe how the punch penetrates right up to the end of the sebaceous gland without exceeding the inferior segment. When the forceps pull the dermis, the unit is still attached, but these adherences are weak and the plane of the forceps will end up breaking them. Again, cut at a controlled depth, the unit is still not liberated, and the moving of the forceps to get an atraumatic delivery of the unit. For the delivery of the follicular unit, we use 2 bayonet forceps number 7. The forceps should be placed parallel to one another with points facing each other and at a greater tension possible to the skin and direction of the follicle. The left forceps pinches the follicle at the skin and tugs softly until showing the sebaceous gland. The right forceps pinches the follicle below the gland, placing the tip in an oblique position to augment the contact area and produce the least damage possible. Once held, we must find the trick to make a safe extraction. The basic movement is to gently tug the skin with the left forceps to break the adhesions left. It is fundamental that the right forceps is in parallel position to the skin and that we never pull the unit until it has been completely freed of the adhesions left to avoid transection and trauma. This is a very useful technique as we use it to perform the majority of the extractions. There are, however, some difficult cases where we have developed other movements and combinations to preserve the follicle. Universal. Using the left forceps, we press backwards and downwards. Crossed. Right forceps in an oblique fashion, introducing the point into the hole. Left forceps tugs the opposite direction, moving from right to left. Anterior control. The right forceps gently lifts the unit and holds it against the anterior edge, and the left forceps applies pressure backwards and downwards. Posterior control. The right forceps lifts the unit and holds it against the posterior edge. The left forceps rests on the skin and tugs downwards. Inferior control. We gently lift the unit. The left forceps straightens the skin underneath the unit until both are on the same plane, and posterior tugging extracts the unit. Step. The left forceps rests on the posterior edge, working down step by step until the unit is free. 2 forceps. Left forceps on the skin, right forceps on the sebaceous gland, and tug first upwards and then forwards, up and down. Once we have the sebaceous gland, we pinch the unit on the lowest possible point and we move the unit in an up and down fashion. Anterior up and down, it's a combined movement, the same as an up and down, but in the anterior control position. Roller. The left forceps performs a posterior or anterior rotation on the skin. S. Posterior semicircular movement of the left forceps on the wall of the follicle, followed by a posterior semicircular movement of the right forceps to release the unit. Anterior approach. The left forceps comes from the front, right forceps presses on the skin, and this is very useful in temporal areas. Let's move on to our next issue, the introduction of the implanter usage. Since Dr. Toy began using the first implanters in the early 90s, there have been many opinions written both for and against their use. For us, it is an essential tool. We usually use 2 techs and 4 implanters, 2 of 0.8 mm and 2 of 1 mm. We work at the head of the patient with the 2 times magnifying glasses. Our vision is fixed always on the receptor area, and we never look at the auxiliary table, but we know by heart where we can find our tools. The loaded implanters are always on the front part of the table with the point facing outwards. The unloaded implanters are left on the internal part against the petri dishes with the point facing to the front. The surgeon's hand, as it is blind, dominates the surgical side and always has preference over the nurse's hands. As in all surgical procedures, there is never anything passed from hand to hand. The implanter has to roll on the table in a controlled fashion. As we mainly use punches of 0.75 and 0.80 mm for the extraction, it is not necessary to use a microscope to trim the borders. To load the implanter, the nurse holds it in her left hand, supporting the edge of the needle with her fifth finger. The right hand supports the unit by the dermis, places it in the bevel, and turns the head of the unit upwards. Only in this moment we can gently slip the unit through the channel. This delicate action must not be forced, and the unit must be always touched only by the dermis. In our clinic, the surgeon places the unit in the recipient side directly, without the use of pre-designed incisions. We believe direct insertion using a good technique dissects, that means separates the tissues instead of cutting, as we would do with the needle during the pre-designed. We don't use tumescence on the receptor side, it's just local anesthesia. This means that we always have to tense the skin to ease the insertion and diminish the popping. The tension can be anterior, pulling downwards with 2 fingers on the forehead, or posterior, pressing the skin backwards with 1 finger. To insert the needle into the skin, we can either place the bevel looking up, lateral, or straight down. At the beginning and in difficult cases, we advise that the bevel always be placed downwards. When we place the needle with the bevel facing downwards and lower the angle of insertion, we see that there is a point where the needle slips easily into the dermis without force. This is the avascular plane with no bleeding and very important for patients with popping. Once the left hand is in position, the right hand places the point of the needle with the bevel facing downwards onto the skin. The second finger is placed on the upper back part of the button, never on the shoulder. In this position, we perform a forward movement, decreasing the angle between the implanter and the skin. We should notice how, with little pressure, the bevel slips easily through the dermis. The movement must be defined but not be forced, and we must be sure to go completely through the dermis. The needle has penetrated to the required depth. The second finger changes its position to the upper part of the shoulder and shoots, while at the same time we retract the needle from the scalp. It is a rapid and coordinated movement. Insert, change the second finger, shoot, and immediately retract the needle to leave the follicle in the correct position. In cases where the follicle remains a little elevated, we can help using the point of the needle to reinsert the unit. The dermis of the follicle must always be 50% inserted into the skin. As we know, if the dermis remains buried, this may cause folliculitis. Therefore, we will always have to be rescuing follicles which have been inserted too deep. In case of follicles without dermis, the movements of insertion must be slower and more controlled to avoid positioning the unit at an incorrect depth. Because of this, we advise to leave skeletized units until the end or combine them with other follicles with dermis to make multiple units. Always begin the positioning of the units from the forehead and move backwards, and from the center towards the sides. With experience, there is no difference between going backwards or forwards, depending on the comfort of the surgeon. In posterior areas, we usually invert the process from forwards to backwards. For the crown, we start from the central wheel in centrifugal form. The implanter gives us the technical possibility to recreate normal densities. There is no technical limitation, and the only limitation comes from the characteristics of the patient. Achieving appropriate density and correct angle is a question of practice. In summary, there are different methods and tricks which are not covered by this video, and they can only be learned with practice.